Well, welcome everyone, and thank you for joining us today. My name is Bill Manning, and I'm Executive Director of ASPI. A quick footnote, I've been on active surveillance since 2009, and I'm still a member of my local support group that got me started on this journey. Our purpose here is to educate individuals about options regarding active surveillance, which is not a treatment, but a management plan. I would like to remind everyone that we are not anti-treatment, but anti-unnecessary treatment. We are not here to dispense with any medical advice. Nothing said during these meetings by our speakers, ASPI, or the audience should take the place of consultations with your medical professionals. We're going to hold all questions until after the speaker's presentation. You can submit questions in the chat box, which we will try to address. Please keep your questions limited in scope. Our speaker does not have time to review your entire case history. At that time, you can also click the raise hand button from the bottom of your Zoom window toolbar, and if there's time, we'll try to call on you. During the meeting, please keep yourself muted. The speaker presenting here today is generously donating his time, so we want to be respectful of that. This meeting is being recorded and will be available on our website in approximately 1 week. You will get an email notifying you when it's ready. Also, if you subscribe to our YouTube channel, you'll automatically be notified when a new video is posted. So, without further ado, we'll have a few words from Howard Walensky, the organizer of this meeting, to introduce our guest. So relax, enjoy the meeting, and I hope you leave a little bit smarter.
Well,
Take it away.
thanks, Bill. Yeah, I'm Howard Walensky. I've been on active surveillance for 15 years now. ASPI has been following micro-ultrasound, our subject of the day, ever since we launched in 2018. Micro-ultrasound was the subject of one of our earliest webinars in 2021. We've watched micro-ultrasound mature, and recently, in a significant study presented at a major medical meeting earlier this year, it was demonstrated in doctor terms to be non-inferior to MRI. I don't know why, but non-inferior sounds funny to me as a layman, but it means both are about equally effective in early detection of prostate cancer. Uh, the lead researcher on this study is our speaker today, Dr. Adam Kinnaird, Canadian surgeon scientist and assistant professor in the Department of Surgery at the University of Alberta, Edmonton. He serves as chair of the Alberta Prostate Cancer Research Initiative. He specializes in imaging, targeted biopsy, and focal therapy for prostate cancer, blending patient care with research to advance diagnosis and treatment of the disease. Beyond his clinical and scientific achievements, I understand Dr. Kinnaird was a varsity ice hockey player at the University of Alberta. And I wonder if the doctor has played hockey with his co-author, Dr. Klotz, pioneer in AS at the University of Toronto. I know that Dr. Klotz is a hockey player. So before we get started, Dr. Kinnaird, can you address that?
Yeah, I've talked with Laurie about that. We've never played together, but I'm sure he's a Leafs fan and I'm an Oilers fan, so we don't get along when we talk hockey.
So the floor is yours. We will have questions and answers, and we'll get on to that as soon as you're done. Thanks.
Sure. So thanks for inviting me to this meeting. It's great to see over 100 people in attendance. I saw, looks like some people are from all over the world. I think I saw Iceland, I saw Canada. Some people had other places next to their names, so that's great. Really, really happy to be here. So I'm going to share my screen so that everyone knows sort of where I come from. And I am born and raised in Canada. I did most of my training, my MD, my undergrad, my PhD, my residency at the University of Alberta. And then I went to UCLA to do a fellowship with Leonard Marks, who's another one of the pioneers of active surveillance, and especially a pioneer of active surveillance using MRI guided biopsy. So I spent a year with Lenny and then came back in 2020 to start a targeted biopsy and focal therapy program at the University of Alberta. While I was at UCLA, a new technology was basically coming to fruition. And this was micro-ultrasound, high resolution micro-ultrasound. And so I have been fortunate to have this machine for the last 5 years and have been able to study it through various disease states. And I'm going to talk to you about some of them today. And I'm very happy to answer questions. I mean, I like questions at any time, but I guess the rules are will be questions at the end. So just type in the chat box or hold your questions till the end. So I do have a disclosure. I have received funding from the company that makes the only commercially available micro ultrasound device. The company is called Exact Imaging, and the device is called Exact View. Exact VU. So my goal today is to review micro-ultrasound technology for those who haven't heard of it, to talk about micro-ultrasound in biopsy-naive men, which I'm sure the majority of you are not, but this was the first global randomized control trial that was just published in March in a really good journal called JAMA to show that it is basically similar to MRI-guided biopsy. Then we're going to talk about the work that has been done in micro-ultrasound for active surveillance. And then I'm going to present some upcoming trials in micro-ultrasound, both in biopsy-naive and active surveillance patients that are international trials. And to talk about a little bit about AI and show you what we're doing with that. So prostate biopsy really has changed over the last 125 years. It started off as an open surgical procedure. So it was an open perineal prostate biopsy. This was fraught with complications like exsanguination, erectile dysfunction, incontinence. And then in the 1930s, it became a finger-guided biopsy. So you put your finger in the rectum, you feel the nodule, and then you take a sample with a needle. And then in the 1970s, so 50 years ago, this is where ultrasound-guided biopsy started to become a thing. And this has really been the standard of care for about 40 to 50 years. And the issue with ultrasound-guided biopsy is that while you can visualize the prostate gland, you can't actually see where the tumor is in the prostate. So you had to take blind biopsies, random biopsies. Then about 10, 15 years ago, MRI-guided biopsy became a thing. And the advantage to MRI-guided biopsy was sort of twofold. One, if you had an MRI and the MRI was negative, then you can safely avoid an unnecessary biopsy. And then secondly, if you have an MRI and it shows a lesion, then not only do you take your random biopsies, but you can take targeted biopsies as well and have a greater chance of actually finding the prostate cancer that is there. About 5 years ago, studies started coming out for PSMA PET guided biopsy. And now in 2025, there's level 1 evidence for micro-ultrasound guided prostate biopsy. So this is what the machine looks like. It's a standard ultrasound probe that goes up the rectum. I shouldn't say it's a standard ultrasound probe. It's still is a probe that goes up the rectum, but it is shaped in a special way that allows for like crystals to be placed 90 nanometers apart. And because of this, it increases the resolution from 9 megahertz to 29 megahertz in terms of its frequency, and its resolution goes down to about 70 microns. So 70 millionths of a meter. And what this means is that prostatic ducts are about 100 microns. And with prostate cancer fills the prostatic ducts. So what you're looking for when you're imaging with micro-ultrasound is a filling of these ducts. So the standard conventional ultrasound can't resolve those, while the new micro-ultrasound can. And I'll show you what this looks like. So on the far left-hand side, this was the first ever transrectal ultrasound image of a prostate gland that had cancer in it. So this is the prostate gland right here in the top middle of the screen. And you can see that while you can see the shape of the prostate, you really can't make out much in it. In the middle frame, this is what a conventional ultrasound looks like. This is in an axial view. And you can see the peripheral zone here and the transition zone here, but you can't really make out any lesions in the prostate. And then on the right side, this is what a high resolution micro-ultrasound looks like. And in fact, the image on the left, in the middle, and the image on the right are taken from the same prostate gland at the same plane. And you can just see how much more detail there is in the high resolution micro-ultrasound. In fact, you can actually see scar tissue from where a previous prostate biopsy sample was acquired. And so this is what a lesion looks like on micro-ultrasound. If you look, this was a study that was done at UCLA while I was a fellow. And Dr. Brisbane out of UCLA is the leading author on this. And what this shows is this, again, shows micro-ultrasound on the left and then conventional ultrasound on the right. And this is the prostate has been removed from the patient and we're scanning it on the tabletop. And what you can see on conventional ultrasound is nothing. You can't see the lesion at all. But then you can actually see that lesion on the high resolution micro-ultrasound. So what exactly you are imaging? I said you're imaging sort of the ducts. And so what I'm showing you now is a prostate that has been removed and it's been sliced up and it's being looked at under the microscope. And so here, this is the histology of the prostate. You can see the pink is the connective tissue and the white are the ducts. And when you image that with a micro-ultrasound, what you end up getting is the Swiss cheese pattern. The Swiss cheese pattern are basically they're hollow prostatic ducts. This is a good thing. This is what you want to see. This is given a score of 1 out of 5, the lowest risk that there is. And then when there's prostate cancer present, then when you image this, then you lose those ducts and you start seeing certain patterns like this white pattern right here. This would be a Primus 3 or a Primus 4 lesion right here. And so in about 8 years ago, a radiologist in Toronto came up with a scoring system for the micro-ultrasound. So with MRI, I'm sure many of you are aware of the PIRADS scoring system. And so the PIRADS scoring system is a score of 1 to 5. It's a Likert scale, with 1 and 2 being considered negative, and 3, 4, and 5 being considered positive, and 4 being more positive than 3, and 5 being more positive than 4. So the radiologist made this analogous scoring system for micro-ultrasound called the Primus scoring system. Again, 1 and 2 are considered negative, 3, 4, and 5 considered positive. And what you can see here is you can see that on 1 and 2, you can still see the prostatic ducts. These are good features that make you feel like there is not prostate cancer there. And then when you start to get to 3, 4, and 5, then you have a loss of those ducts. You start getting some of these white patches or starry sky appearance, or you can actually see a dark lesion right here, or you can get this tiger striping happening as well. All right. So I said that the first place that I'm just going to mute less foul. There we go. Okay. So so in biopsy naive men, this is the first place that it was really tested. And there were probably 20 studies that were out there showing that micro-ultrasound is similar to MRI for the diagnosis of prostate cancer in biopsy naive men. So in men undergoing their first prostate biopsy. But these were all prospective observational studies, not randomized control trials. So they didn't have high enough level of evidence to really cause change. So what we did is we set out to do an international randomized control trial called OPTIMUM. This is the study that was published in JAMA in March of this year, and it was presented in Madrid to a large audience. And what this trial was, is this trial was an interesting one that in a randomized control trial, usually you have two arms. Usually you get randomized to just one arm, the standard of care, or the experimental arm, the intervention arm. But this trial actually had three arms. So in this trial, you would get randomized to either get a micro-ultrasound guided biopsy, or you would get randomized to receive an MRI prior to biopsy. Some of these men went on to a standard MRI guided biopsy, and some of these men had a combined micro-ultrasound and MRI guided biopsy. And what was unique about this arm is that when we were doing the biopsies, when we were using both micro-ultrasound and MRI, we were blinded to the results of the MRI until we were done taking our micro-ultrasound samples, doing the assessment with the micro-ultrasound. And then we would unblind ourselves to the results of the MRI. So we would see the results of the MRI, and then we would sample any lesions that we felt we missed with the micro-ultrasound. And then at the end of the day, the primary outcome of the study was the detection of clinically significant prostate cancer, defined as Gleason grade group 2 or more, or otherwise Gleason grade 3+4 or more. And so this study was actually planned to be about 1,200 men in size, but with an analysis that was done at the 50% mark. And at the 50% mark, the results were so promising that the trial was actually stopped early, because it was deemed that if we had kept going with the trial, that would not affect the outcome of the trial. So this trial was stopped early for success. And so this trial was done at 20 medical centers in 8 different countries in North America and in Europe. And in this, we had about 121 men who got randomized to the micro-ultrasound only, 331 men who were randomized to the standard MRI guided biopsy, and 226 men who were randomized to the combined arm, where we were blinded. And what we found that when you biopsy using micro-ultrasound, we found that clinically significant prostate cancer was found 46% of the time, whereas when you used MRI guided biopsy, it was found 43% of the time. And this trial was designed as what's called a non-inferiority trial, which is a really, ridiculous way of describing things, but it's the way that statisticians like it. And what this means that the micro-ultrasound is similar. It is not worse than MRI at detecting prostate cancer. Now, when we look at these results another way, I'm going to walk you through this. This plot shows on the right-hand side that at this dashed line here, this 0, this is where if a dot were here, there would be no difference between micro-ultrasound and MRI. They would be considered, equivalent. And then we powered this trial to make sure that it was at least not 10% worse. So if you're on the left-hand side of this 0, if this dot falls on the left-hand side of 0, it means that MRI is better than micro-ultrasound. If the dot falls on the right-hand side of the 0, it means that micro-ultrasound may be better than MRI. So as you can see here, all the dots fall on the right-hand side, all favoring micro-ultrasound. But because we stopped the trial early, it means that there is a degree of error, a certainty of error that exists, which means these lines here, these are the error bars, they cross that 0 line, which means that we cannot say that micro-ultrasound is superior to MRI. We have to say it is non-inferior to MRI. So that's what that means. In general terms, this means that in biopsy-naive men, micro-ultrasound can be potentially used in place of MRI when performing a biopsy. Now, something that is becoming really prevalent throughout the world is the concept of only taking targeted samples. And this is important for the active surveillance population, because what has been shown when you take targeted samples only and not systematic samples is that you detect about 50% less grade group 1 or 3+3 prostate cancer. That means that you are not going to be diagnosing men with low risk cancer that needs to be watched. That means you can potentially save men unnecessary monitoring, blood tests, imaging tests, further biopsies by not diagnosing that grade group 1. So when we compared targeted biopsy only, because in this trial, men had both targeted cores taken and the systematic cores taken, we found that micro-ultrasound detected prostate clinically significant cancer 38% of the time versus MRI was 34% of the time. And then when both were used, 40% of the time. So micro-ultrasound is not just doing a good job with the biopsy, but it's also doing a good job with targeted biopsy. And then what this graph shows is basically how good the Primus score is and how good the PIRAD score is. And so on the right, this is very much to be expected. This has been shown time and time again. On the right-hand side, this is when the PIRAD score goes from 1 all the way up to 5. What you can see is that the rate of detection of clinically significant prostate cancer, shown in the orange or reddish color, increases as the Likert score increases from 1 to 2 to 3 to 4 to 5. So that's good. That means that a PIRAD score of 5 has about an 85 to 90% chance of finding clinically significant prostate cancer, whereas a PIRAD score of 1 did not find any clinically significant prostate cancer. It still did find some grade group 1 prostate cancer, but no clinically significant prostate cancer. And then when we look at the Primus scoring system, so again, this is the first time that the Primus scoring system has been used in an international randomized control trial, we find that it is actually very valuable, where you see an increase in the amount of cancer detection that we find as the Primus score increases. And really nicely, the Primus 1 score, that Swiss cheese pattern, when that's present, we don't find any clinically significant prostate cancer or even any prostate cancer. So that's a really reassuring thing that would have a high negative predictive value, or something that might be good for screening men for prostate cancer. So in the biopsy naive space, I'm just quickly going to switch to, so where do we go from here? So I'm just going to go back to this, and I'm going to say one of the main problems with the OPTIMUM trial, not a problem, but a limitation with the OPTIMUM trial, is that every man got a prostate biopsy regardless of what the imaging showed. So even if the imaging was negative, Primus 1, Primus 2, PIRADS 1, PIRADS 2, you still had to get a prostate biopsy. And that was because of safety, because we didn't know how well the Primus 1 and 2 scores would work in this trial. So every man got a biopsy. But in the real world, that's not really how it works. In the real world, if you have a PIRAD score of 1 or 2, you typically safely avoid a prostate biopsy, unless your PSA is so high that it can't be explained by the size of the prostate. So what's called your PSA density is markedly elevated, then you would still do a biopsy. So what we have going on here now is we have several ongoing trials that I lead. The one I'll talk about first is in the biopsy naive space. So they're called music screen and music active surveillance. And music stands for micro-ultrasound in cancer, and screen is because the trial is designed to see if we can screen out men who do not need prostate biopsy using micro-ultrasound. So in this trial actually has 17 sites from around the world in North America, South America, Europe, and Asia. In the United States, the places that are participating are Cleveland Clinic, Yale, UCLA, UT Southwestern, Mount Sinai in New York, and maybe one or two more that I'm forgetting. And what this trial is about is this is where men who are age 50 to 70 with a PSA of 3 to 20, who are biopsy naive and have had no prior imaging or prostate biopsy or prostate cancer diagnosis or reason why they can't have an MRI or a biopsy, get randomized in a one-to-one manner to either receive MRI or micro-ultrasound. Where this is different than the OPTIMUM trial is that if the PIRAD score is negative, is favorable, or the Primus score is favorable, and the PSA density is not out of control, then you avoid prostate biopsy. Whereas if the imaging is positive or the PSA density is high, which is our safety net in this trial, then you go on to a combined targeted plus systematic biopsy. And the primary outcome is the detection of Gleason grade group 2 or Gleason 3+4 prostate cancer. And then these men are followed for 8 years as per standard of care in whatever their local region designates as standard of care. So a PSA once a year, a PSA once every 2 years, an MRI whenever. We're very accepting of whatever standard of care is. And then we will figure out how many men who deferred biopsy actually get diagnosed with prostate cancer within the next 8 years. So this study is open in Edmonton. We opened it in May, and we've already randomized 100 patients. And so we're going to go up to 150 patients at my home site, and then the remaining 1,100 patients are going to come from around the world. So now let's talk about micro-ultrasound in active surveillance. So far, there is pretty much some limited information for the use of micro-ultrasound in active surveillance. There really are only two trials, one retrospective and one prospective, that have looked at micro-ultrasound in active surveillance. And one of them was published by my group in 2022. And this was a retrospective analysis of 128 men who were all on active surveillance for Gleason grade group 1, so 3+3 prostate cancer. This combined, they could have been on active surveillance for any period of time, and they were undergoing either a micro-ultrasound or an MRI-guided biopsy. And the primary outcome was upgrading to Gleason 3+4 or Gleason grade group 2. And what we found is that there was no difference between groups, between the MRI and the micro-ultrasound, where micro-ultrasound detected 98% of the upgrades and MRI detected 85% of the upgrades. And the really reassuring thing is that when the Primus score was negative, 1 or 2, versus positive, it had a negative predictive value that was very high of 97%. And this means that there was an odds ratio, you were 15 or 16 times more likely to get upgraded to Gleason grade group 2 or higher if the micro-ultrasound was positive compared to negative. And really interestingly, we found this concept of a double negative. So when both the micro-ultrasound and the MRI were negative, there were no upgrades detected in any of these 128 men. So that's a really promising thing, and we'll have to see if it bears out in future trials, because obviously it will be really nice where you could potentially avoid prostate biopsy during active surveillance if you have two imaging tests that are both negative. So that's a very provocative comment, and I hope it bears out, but I'm not 100% sure that it will, because again, this was just a retrospective study. The second study that has been looked at in active surveillance for micro-ultrasound and MRI was a prospective study. This was out of Italy. It had 100 men. And again, it was upgrading to grade group 2 or more at confirmatory biopsy. So again, to remind everybody, the way that these biopsies are named is you have your diagnostic biopsy. That's the first prostate biopsy that you have that shows prostate cancer. And then if it shows low-risk disease, then you have a second prostate biopsy, typically about a year later. And that's called the confirmatory biopsy to confirm low-risk status of the disease. And then about every 3 to 5 years, you may have a surveillance biopsy to make sure that it has not progressed in histology and aggressiveness. And what they found here is that, again, there was no difference between groups. Micro-ultrasound detected 91% of the upgrades, and MRI detected 94% of the upgrades. And again, it has a good negative predictive value for detection. Now, they didn't comment on this double negative possibility. So we'll have to see what it shows. So what we have going on right now in terms of trials for active surveillance in micro-ultrasound is an international trial. This is another trial that I lead called Music Active Surveillance. And this is a prospective paired diagnostic trial, which in plain English means when you go for your biopsy, you get both an MRI and a micro-ultrasound assessment. And then within the same patient, we're able to compare what each imaging test found. So this is powered to enroll 210 men. We currently have 7 international sites. So we have Vancouver, Edmonton, Montreal, UCLA, Humanitas University in Italy, Marseille in France, and Zagreb in Croatia are participating in this trial. And something that's really important, and something I should have mentioned actually earlier, is that micro-ultrasound has just like MRI has a learning curve, just like anything, you pick up any skill, there's a learning curve. You're better at it the more you do, just like golf. The more micro-ultrasound you do, the better you are at doing it. So the company actually has a mastery program where you do about 90 cases and it monitors your first 90 cases. And then you graduate from that program and you are considered to be an expert of this. So to participate in both of these trials, the Music Screen and the Music AS, the people performing the micro-ultrasound have to have passed this mastery program. And so the way that this trial works is patients with grade group 1 prostate cancer who require a confirmatory biopsy are enrolled in the trial. They're excluded if they have a contraindication to MRI or biopsy because you have to get both of those in the trial. The participant undergoes a prostate MRI to which the urologist is blinded to the results. Then in the biopsy session, the urologist takes any targets that look suspicious on micro-ultrasound, so any Primus 3 to 5 targets. Then the MRI is unblinded. The urologist takes any PIRADS 3 to 5 targets that were missed by the Primus score, and then the systematic biopsies are sampled and then submitted for histologic review. And so we so far have enrolled 135 patients worldwide as of this month, and we're going up to 210. So I am hopeful that in about a year or two, we will be able to publish these results, and then everyone on this call will be able to see if micro-ultrasound is non-inferior to MRI for biopsy during active surveillance. So the last thing that I want to talk about before I take questions is I want to talk about the use of artificial intelligence in micro-ultrasound. So basically, AI is being used very, very heavily in all diagnostic imaging modalities. So it has been shown that AI can be as good as radiologists or even better than radiologists at reading chest X-rays and chest CTs. In terms of pathologists, it has been shown that AI can be as good as expert genital urinary pathologists at grading prostate cancer. And so now what has been done is there has been work in MRI where there has been use of AI in MRI. And now it's trickled down to micro-ultrasound. And as micro-ultrasound is the newest kid on the block, it obviously is the furthest behind. But this is an example of a model called Prost and Found that is based out of Queen's University in Ontario. And what this is on the left here, this is an example of 3 micro-ultrasounds showing benign tissue, and then the heat map on the middle panel showing that it is blue, it is benign, and that those biopsies could potentially be avoided. Whereas on the right, here are micro-ultrasound images that were found to be prostate cancer when the biopsy was taken. And here are the heat maps showing that these biopsies should indeed be taken. So this is a very exciting opportunity for live imaging, point of care imaging with micro-ultrasound combining AI, where you would put in the ultrasound probe, you would do your sweeps, assess the prostate, you would look at it with your own eyes and say, this is where I think regions of interest are. And then you would flick on a button, and then you would see if the computer agrees with you. And then you would be able to target the biopsy even better. So, in conclusion, micro-ultrasound offers a potentially cost-effective and portable alternative to MRI. So, in Canada, at least, MRI costs about. So, in Canada, of course, we have provincially funded healthcare, so we pay it through our tax dollars. But if you do get a private MRI, it costs about $1,000, whereas a micro ultrasound costs the system about $200 to $300. So it is cost effective. Also, an MRI requires sophisticated infrastructure housing a very heavy magnet that needs to be cooled to a very cold temperature with liquid helium, whereas micro ultrasound can be used basically anywhere where there is electricity. Micro-ultrasound is non-inferior to MRI for the detection of grade group 2 prostate cancer in biopsy-naive men. That's the OPTIMUM trial. And then early observational evidence suggests micro-ultrasound may be useful in active surveillance. And we have several trials that are currently ongoing. And the nice thing with all these trials is that everybody's images get stored in a central imaging repository so that we can have thousands of images that we can then use AI on to develop these models. So with that, I'd like to leave time for lots of questions and happy to take any questions. Thank you very much.
Okay, well, terrific presentation. Micro-ultrasound has really been making the moves. It sounds like it's going to revolutionize what we patients go through. And although I don't know if the hospitals will like it much because it doesn't have the same revenue model as MRI, doesn't have the same maintenance. But we're going to have some questions. I'll ask a few, then I'll turn it over to Jeff and then over to David, and then we'll just sort of rotate it through it. But you mentioned the training program. I got an email from a patient in Florida. The doctor bought one of these machines. He didn't know how to interpret it. And so the patient was cut adrift. I had to refer him to the company. And so are you saying that we should, well, first of all, how widely available is it, micro-ultrasound? And secondly, should we not go to doctors who do not have master's graduation?
Yeah, so there are about 300 of these machines worldwide. I would say if you can't drive stick, if you can't drive a manual transmission, don't buy a manual transmission car. So if you can't interpret a micro ultrasound, don't buy a micro ultrasound or don't offer it to your patients until you have trained and learned how to do that. So definitely, we can't let the technology get ahead of the person using the technology. And so I think it's actually very admirable that that the company offers a training program. It's probably important for them in the early stages of their company development to make sure that their technology is being used safely so they don't run into troubles. But in my mind, it's a must that the urologist using the technology does the training program. Otherwise, you're just going to be doing a blind biopsy.
Okay, I'll ask one more question and turn it over to Jeff. Or maybe I'll ask two more questions since I'm chairing this. At any rate, I found it interesting that you're looking at potentially combining MRI and micro-ultrasound. A lot of the history of technology in medicine is the old technology doesn't go away. It's just included. But, realistically, from a cost point of view, what evolution do you see with these two technologies? Do you think it's going to be both? I know you're going to be studying it, or do you think, one will dominate?
Yeah, so I think that there's definitely the reason I'm doing these trials is to try to see, can micro ultrasound safely replace MRI? Now, I am a big believer in MRI. I've drank that Kool-Aid. So MRI is excellent for prostate cancer. I do not want to downplay that at all. Any biopsy that you have right now on active surveillance should probably be MRI informed because that's what the evidence shows. As we accumulate more data, it is possible that micro ultrasound is able to replace MRI, but I can't make that claim right now. We're currently studying it. Now, from a health economic standpoint, which as a Canadian citizen, where my taxes are paying for our country's healthcare, that is a really important thing to me because I want my money to go the furthest that it possibly can, the biggest bang for the buck. So if you can do the same, find the same amount of cancer for 1/3 of the price, that sounds like a really good thing to me. Now, there are also other instances where patients simply can't have an MRI. Some patients with pacemakers, you need to do special things to be able to do an MRI with a pacemaker. You can, if you have ferromagnetic foreign bodies, you cannot have an MRI. If you have hip replacements, you either need to have an endorectal coil or it can completely obscure the prostate. If you're claustrophobic, you may not want to be in an MRI scanner for half an hour. So there are many reasons why MRI can potentially not be done in a patient. And the only reason a micro ultrasound cannot be done in a patient is if they lack a rectum, like their rectum's been surgically removed, or they have something very rare, like they're on immunotherapy and having a reaction with their colon. So the converse of that is that a micro ultrasound requires a probe in the rectum. And a lot of men want to try to avoid having a probe in the rectum, whereas an MRI is something where you just lie there and you go into a machine. So there's arguments made on both sides.
Let me ask this. I mean, I used to get claustrophobic personally in an MRI. I recently had a biparametric MRI. I didn't get claustrophobic. Prior to that, I had thought about getting a micro ultrasound, but I'm in Chicago and I'd have to go to St. Louis or Cleveland or Columbus, Ohio to do it. So let me ask you right now, for somebody claustrophobic who doesn't have a micro ultrasound available, how do you think about biparametric MRI? And many of the people here may not even know what that is. So what is that?
Yeah. Okay. So basically, when we say prostate MRI, that's code for multiparametric MRI. And multiparametric MRI just means that you actually have 3 sequences that are done on you while you're lying in that machine. One of those is contrast. And so that's why you have an IV and they inject the contrast through you. And that takes quite a bit of time to image. A biparametric MRI only has 2 phases. The phase that is removed is the contrast. So you don't need contrast anymore. So you don't need an IV. You don't need a radiologist in the building. So it can be done overnight. So you can really run that magnet through. So that's a good thing for the healthcare system. And it means that the MRI goes from being like half an hour to being like 10 or 15 minutes. And so it is a lot faster. So I think that this is something else that has been studied very intensely. And there's a nice trial called PRIME out of the UK that is an international randomized control trial. And the initial results that have been presented at meetings show that it is basically the same as a multiparametric MRI.
I hear you. Jeff, how about taking on some?
Good morning, doctor. I'm a very frustrated Sharks fan, so I'm leaning a little bit towards the Oilers, of course.
Bless you.
We have a question from a Canadian fellow named Bill Wood. He says, for comparison with micro ultrasound, were all MRIs done on a 3T machine with gadolinium?
Yes, 100%. And not only that, but you had to have shown that your center is excellent at doing MRIs. So the average number of prostate MRIs that the centers had done was like over 1,000. So they were truly expert users in prostate MRI, because that's a really good point, that if your comparator, the MRI, is done poorly, of course your new technology is going to look good. But the comparator was actually very high quality expert level.
All right, doctor, we have another gentleman named John Burns, and John is asking, how does a fusion biopsy fit into the choice you talk about?
Yeah, so a fusion biopsy is typically the term fusion biopsy is uh, an MRI device assisted biopsy. So it's an MRI, and then that MRI gets uploaded onto any one of the machines that is commercially available. So Euronav, Artemis, Coelis, BK, there's many out there. And then that is the type of biopsy that we've all become accustomed to now. A micro ultrasound is different than a fusion biopsy in that you are actually visualizing the lesion in real time. With a fusion biopsy, the MRI, you're using technology to try to bring that MRI that you had weeks before into that room. So you can imagine that as you fuse that MRI to the ultrasound that you're doing, it's possible that it might be misregistered. And that means that when you're biopsying in one location where you think the lesion is, you're actually missing it. So that's one of the theoretical advantages to micro ultrasound. Now, I will say that the micro ultrasound device actually has fusion technology as well. So this is why you can do a micro ultrasound MRI fusion biopsy.
So, doctor, Canadians have been known to go out and have pizza and beer. Now, if a fellow went out the night before and his team won at hockey and he really overindulged, would that, a full digestive tract have any effect on an MRI?
It probably shouldn't, based on the fact that you're imaging the pelvis.
Yeah.
So I don't think that on an MRI, I don't think you have to. I honestly don't know if you have to fast or not, but it would not limit the ability to rectal gas. So if you're farty, that certainly can limit an MRI interpretation. It does not limit a micro ultrasound interpretation, but it does make it a little bit trickier for the guy who's doing the micro ultrasound because you're letting out all the gas through the ultrasound probe, so the room gets a bit stinky.
All right. Oh, Canada. One last question, sir. A former Canadian named Jeff McLennan is asking, I'm 72 now, so how does the micro ultrasound relate and treat a fellow as he's getting older? I mean, how far do we have to go? Some of us might live to be 90, more, some of us might not. So in terms of the micro ultrasound and the MRI, you've shown fairly good equality, but what do you recommend for the older fellow?
Yeah, so I would probably say it's the same thing for regard if you're on active surveillance, as long as you're planning on staying on active surveillance, which means that at some point you would want active treatment. Of course, if you get to the point where you say I never want to have any treatment for my prostate cancer, then that's where watchful waiting is what you would switch to. And but as long as you're on active surveillance, then you do still need assessment with some form of imaging plus minus a biopsy every 3 to 5 years.
Okay, thank you, Dr. Howard. That's all. Should we shoot to David?
Yeah, David.
Yes.
Thank you, sir.
Doctor, thank you so much for your incredibly interesting presentation. Can you guys hear me all right?
Yes.
All right, great. One practical question. If we want to get a micro ultrasound, how do we find one near us? Do we call Exact Imaging and say who has the nearest micro ultrasound device near Jacksonville, Florida, for example?
I think that's probably the best way of doing it. It looks like somebody just Harley Myler just said go to the website. There must be a website on the company's
Yeah,
that the company has.
they do have one, and you put in your zip code, for example, or your country, and it'll give you a practitioner. Although I don't know if it classifies them as being masters or not.
So the website would be exactimaging.com, if I were to guess.
Yeah, I'm not 100% sure. If you Google exact imaging, then
Okay.
it will come up.
Okay. Thank you so much. I really appreciate that because I'm personally interested in getting one done as soon as I can.
Great.
Came across a discussion of micro ultrasound micro bubbles as contrast. Can you help me understand that? I'm sorry, I'm not. Contrast
Yeah,
enhanced ultrasound CEUS uses microbubbles filled with gas, which
Yes.
enhances. Go ahead.
Yeah, for sure. So that's a different technology. That's called multiparametric ultrasound. That
Uh,
uses standard conventional ultrasound, but it just uses a couple different phases of ultrasound and things like IV bubbles to
hmm.
image vasculature with the theory that tumors are more vascular. So you would see more bubbles in the tumor than surrounding benign tissue. Now, that could potentially be done with micro ultrasound as well. And it's something that could be studied in the future, but there's no evidence for that yet with micro ultrasound.
Okay. Um, on the well-trained part, so we find a machine that's nearby. Should we ask the doctor, does he have a master's degree from exact imaging? How do we politely ask whether or not they're expert at using the equipment?
I bet you that I bet you could contact the company. If you go on their website and you find there's one near you, you could probably ask the company if they have done. You get a little certificate, but I've got to admit I don't post the certificate.
Okay.
Anybody who comes to me for a micro ultrasound, they don't know that I'm an expert user. They just assume I am.
Okay.
So probably the company, or you could ask them if they've done their training modules. I don't know. I'll leave that one up to you.
Here's a quote from some research. The Pensa Brisbane et al. 2024 study comparing micro-ultrasound to MRI states, quote, however, micro-ultrasound had higher false positive ratios than MRI, similar to other studies. Should that be of a concern of ours? And
Yeah,
I'm
so that's
sorry, I'm
that's a great
bringing
study.
up a
That's
study that's really an
yeah,
outlier.
no,
I'm not sure.
no, not at all. That's a great study. That actually, some of the images that I showed today were from that study. So I'm a co-author on that study as
Oh,
well.
great.
And what that study shows, and what other studies have showed, is that I kept mentioning the negative predictive value. That the negative predictive value is very good. Something that micro ultrasound does do right now is with the current Primus scoring system that we're using, is we may be overcalling things. So we may be saying that like this lesion does look suspicious.
Mm-hmm.
And so we're taking additional biopsies from this lesion, which means that we are falsely positive, but it's actually a negative lesion. So with time, I think with sort of so the PIRAD scoring system has gone through several iterations from PIRADS 1.0 to 1.1 to 2 to 2.1. Primus is going to undergo several iterations and will get better. And then I think that really what will happen now with AI is AI will help with improving the positive predictive value.
Great. Thank you so much for that. This is a generic question that came in on the chat box, and I'll present it. This gentleman or person's asked, is there any record of cancer? I'm assuming they're talking about prostate cancer in this case, killed by the immune system all by itself without having to have outside intervention. I
You
thought I
know,
would
I'm not
ask the
really.
question.
I'm sure. So I'm not okay. When I'm not 100% sure of that. Certainly, I haven't read anything about that, but it is possible that that like our immune system is constantly getting rid of cells that are mutated and bad all the time, just like it gets rid of viruses and bacteria. So I would assume that there would be microscopic things that get mopped up, but I've never heard of just relying on your own immune system to get rid of prostate cancer. I would not recommend that.
And maybe I can interject something. Actually, Dr. Klotz is a believer in even in low risk prostate cancer of some disappearance of the cancer, presumably as a result of the immune system. And I don't know, I think Bill Manning, I know in my case, I was diagnosed 15 years ago, and I had a single core of Gleason 6. Urologists tried to rush me into surgery. I went on surveillance, which was rare 15 years ago. And I had 4 subsequent biopsies. I had 6 biopsies altogether, and only one of them was positive. So what happened to the cancer? And there's a number of guys who are in the same boat as me. I don't know if Bill Manning is one. There's probably others on the call where the cancer, for whatever reason, disappeared, apparently. And so I'll dig something up and I'll post. I wrote something about that a couple of years ago. I'll post that. But at any rate, talk to your co-author, Klotz, ask him what he thinks.
Yeah, I have heard Lori say that before. I do think that what I can tell you for certainty is that if you are diagnosed with low risk prostate cancer and at your confirmatory biopsy, so your second biopsy, we fail to detect any prostate cancer. That is a very good prognostic sign that you can stay on active surveillance for a very long time. If we that's one of the best predictors of prolonged active surveillance is a negative confirmatory biopsy. And how I interpret that is that the tumor itself is very small, so it's hard to hit.
Okay. I had two more questions, Howard, if I have time.
Oh, yeah.
One we've covered, but I just want to maybe emphasize it. A lot of us don't like gadolinium contrast because of the blood-brain barrier issues or different things like that. And are we saying that with micro-ultrasound, we can get what sounds to be the equivalent of an MRI result without having to do gadolinium? Is that fair to say?
Yes. So 100% micro ultrasound does not require gadolinium. So also biparametric MRI does not require gadolinium. So if you really want a prostate MRI, you can request for a biparametric MRI and not get the gadolinium. But that is one of the advantages of micro ultrasound is no contrast agent. Now, I still think that in terms of all the ways that we use prostate MRI, I can't yet say that you can replace MRI with micro ultrasound. The only place I can confidently say that with level 1 evidence is that if you are undergoing a prostate biopsy, that prostate biopsy itself, micro ultrasound is non-inferior to MRI. But all the other studies that I talked about, the music screen, the music AS, those will tell us about the other clinical scenarios.
Yeah, I see John Burns is asking what's wrong with gadolinium. I have to tell you, we've been doing this support group for a number of years now, and it seems that we had gadolinium on the mind, all pun intended, or maybe not, for years. Patients were afraid of it because it crosses the blood-brain barrier, and there was some theory about deposition of gadolinium causing some long-term effects. And there was a class action suit by the actor Chuck Norris's wife, who had a number of MRIs with gadolinium and had some weird results. I would say, if I took the patient's temperature right now, we don't hear that much about gadolinium, but John Burns, there was concern about, like, I don't know, mental issues, memory issues, brain deposition of this. I understand a major study is coming out. It may be out already from the radiologist talking about the safety of gadolinium. I don't know if Dr. Kinnaird has caught wind of that yet, or what's the story with gadolinium?
You described it very well. The concern is there a collection in the brain? And I honestly don't know what the most recent evidence shows, but I do know that it is still heavily used, and MRIs with gadolinium are used every day at basically every center around the world.
Howard, if I could add to that, this is Mark. It's standard for the urologist to still prescribe the gadolinium, even though I ask for no gadolinium, they'll still do it. So you have to be vigilant about it. and they have found that it remains in the system for up to 9 years. And they have found that they can read the MRI, a biparametric MRI, as easily with or without gadolinium.
I,
So
I just had my first parametric MRI. I have sort of a modified active surveillance. I have PSA once a year, and I haven't had a biopsy in maybe 9 or 10 years, and I hadn't had an MRI until recently, but I was going off a study at the University of Michigan where they pretty much have phased out gadolinium for men with low risk, maybe others. Uh, so they're using biparametric. Other centers are too, and they're able to process more cases in a day and get the men in and out of the tubes faster. And frankly, the hospital I went to, Evanston Hospital in the Chicago area, I got a notice, that I had this test coming up, and they sent me a form, but the form said, this is for multi-parametric. So I wrote a note to them and I said, my understanding is that this is for biparametric. They didn't have a form for me. And when I talked to the technicians there, they said 95% the patients coming into their practice at Evanston Hospital still are getting multi-parametric. So, Dr. Kinnaird right. It's probably predominant, but there could be a dramatic change.
Could I ask one follow-up question on that?
Right. Yeah.
Dr. Kinnaird, you're an expert in imaging. Is gadolinium a crutch? If you can get a good image from biparametric, can
When
the
it's
patient honestly say, "Hey, no, I want someone who can read a biparametric as without the need of gadolinium"?
all I can say to that is that when you look at the evidence, you can Google, it's called the Prime trial, PRIME trial out of the UK. There is no difference between clinical decision making, the amount of cancer that's found, whether you got a biparametric or a multiparametric.
So this
Thank you.
is something where the patients, I mean, you have to stand up for yourself and say what you want and see if your doctors can or hospitals can cooperate with you. It was a little bit of a hassle for me to get a biparametric. I mean, something to keep in mind, and again, Dr. Kinnaird is the only official doctor speaking here. But if you have biparametric, even if they're not going to visualize a minor cancer, but they can visualize a more advanced cancer that needs to be addressed. So, but so we're off on the gadolinium uh, races again. But maybe we have some other questions.
Yeah.
Maybe we should open up the floor.
Howard, I have one. Let me ask one because it's kind of a universal and we've talked about it before, and I'll be quiet and it says this is from William Napoli, and he says, can micro-ultrasound image the entire prostate, or are there some inherent blind spots? And maybe the broader question, doctor, is are large prostates a problem for some imaging technologies and not the others?
That's a very insightful question. So, I have yet to meet a prostate that I cannot image with micro ultrasound. I've done over 1,000 micro ultrasound guided biopsies. Um, the technology is easier to use, certainly in smaller prostates, but it can image larger prostates as well. The section of the prostate that is not well assessed by micro ultrasound is the transition zone. It's very good for the peripheral zone. Thankfully, about 70 to 75% of prostate cancers start in the peripheral zone, and only 25 to 30% of cancers start in the transition zone. So there are scoring systems out there for the anterior part of the prostate, the top of the prostate, but it is binary. It's either positive or negative. It's not a Likert scale of 1 to 5. So you're either primus anterior positive or primus anterior negative. But certainly the transition zone is something that is not well assessed, actually, either by MRI or micro-ultrasound. It's trickier. It's trickier in MRI as well, the transition zone. But I would say that probably the transition zone right now is better by MRI than it is by micro-ultrasound.
And then I just wanted to make a general comment. Thank you, doctor. A general comment that where I have my MRIs done, they do use gadolinium, but they do give me a very extensive questionnaire about my kidneys and other parts, and so I think there is some preparations made to maybe screen out men who may not be appropriate for that. I just wanted to throw that out there. It's not just the sort of thing they throw us into.
For sure. So certainly one of the
Yeah.
relative contraindications to getting gadolinium enhancement is a GFR less than 30. So about if your kidney function is about 50% or less.
Okay, doctor, I wanted to thank you for your support of hockey.
Okay.
So Jeff and David, are there questions that we should open up the floor to and have the people ask themselves?
I have a question.
Yep.
Tissue, as I understand it, that I'm trying to phrase the question. Can you do it better with an MRI? They see a mass, they see a darker area, and then they measure it. And so that typically gets you a grade of pyrates 3, 4, 5 of the size of the mass. When you're looking at ductals, help me understand. I think of a mass as a collection of cells that are suspicious for tumor. I don't like to call them tumors. I just like to call them a mass or a lesion. But I think some doctors trying to scare a patient will say, oh, that's a tumor. Not all masses are tumors, if you could clarify that. And then talk about masses versus, what did you call them? Ducts? Prostate ducts.
Yeah.
Thank you.
Yeah, absolutely. I think I know what you're saying. So basically, on MRI, what you're looking at on MRI, the most important sequence on MRI is called diffusion weighted imaging. And what this looks at is the movement of water molecules over time, with the theory that if you have cancer cells that are tightly packed together, it's tougher for water to move through it than if you have benign, loosely packed tissue. So that's called diffusion restriction. And that's what you see in prostate cancer. Now, in micro-ultrasound, what you're looking for is you're not looking at water molecule diffusion. You're just looking for this Swiss cheese pattern to have gone away. So you're looking for this loosely packed tissue to have become more compact. And the way that it looks more compact is by not having any holes in it. So that's why it's the loss of the ducts.
Okay. That was really a great explanation. Thank you so very much.
See, Bill Wood and Ralph Boas are asking, I think I can answer it, but I'll ask you, is a biopsy using micro-ultrasound done through the perineum?
Both, it can both be transrectal biopsy and transperineal biopsy.
Okay, let's see. Is there anybody want to raise their hands and ask?
My hand's raised.
Okay, you first.
As I understand it, biopsies can look at maybe only 1% of the volume of the whole prostate. And so it can miss things. But with the guidance of a micro-ultrasound or MRI, you can look for these masses or other Swiss cheese patterns. And hopefully that's where it is. What's the percentage that if you're just going to focus on a mass or the areas that are indicated by the micro-ultrasound, that you're not going to miss target something? Am I asking that well? Do you know what I'm
Yeah,
trying
I
to
know what you're
say?
saying. I know what you're saying. So I'm going to answer this in a couple ways. So number one, this is why I believe that targeted plus systematic biopsy is still important. So I like to do targeted plus systematic biopsy. So you take the targets and then you take 12 samples in sort of a planned way of doing it, not just willy-nilly, but in a planned way.
Mhm.
So, especially if you're ever going to consider focal therapy, if you want whole gland therapy like radical prostatectomy or radiation therapy, then sure, targeted biopsy is fine. You find some cancer there, it's grade group 2 or more. You say, okay, I want to have my prostate out. We remove your whole prostate. That's fine. But if you want focal therapy where you're only treating a part of the prostate, then you want to be as certain as possible that there is no cancer where you are not treating. And so that's why I think systematic biopsies are very important. The other thing that I wanted to say is that in terms of studying, whether in all these studies that I've talked about, and all these studies, most of the studies that have been done on MRI as well, is that whether someone meets the primary endpoint or not, i.e., is diagnosed with grade group 2 or more prostate cancer, that's based on a biopsy. But it is very likely, it is possible, as you said, you're only assessing 1% or less of the prostate with the biopsy tissue. So it's possible that prostate cancer exists elsewhere in the prostate and you just missed it. And that's a false negative. And so some of the studies that we're doing with micro-ultrasound are that one where somebody asked a question from Pensa and Brisbane et al. That's actually on patients where the entire prostate has been removed and the entire prostate has been looked at by a pathologist and all the areas of cancer highlighted. So it's not based on a biopsy, but it's based on actually the entire prostate. So that will help us with sort of picking up it's better for AI because it's not just cherry picking certain locations and knowing which areas are positive and negative based on biopsy, based on 12 or 15 samples, but based on the entire prostate.
Thank you. Thank you so much. You've done a tremendous job today and helped me, and I hope a lot of others, with a lot of clarification. Systematic biopsy. I understand what a quadrant, multi-quadrant, they usually do 12. Can you describe systematic biopsy in terms of how many biopsies and where?
Yep. So it's described as a sextant biopsy. So the prostate's broken into 6 different areas, the left, right, apex, midgland, base on both sides. And typically you take 2 samples, a lateral and a medial, or an apex, that's if it's transrectal. And if it is transperineal, then you take an apex to midgland and a midgland to base from each of the areas.
Thank you very much. Back to you, Howard.
Okay, well, here's a question from Canada. If the micro-ultrasound approach is not yet available to me here in Vancouver, I don't know if it is, what are the methodology options to biopsy a, quote, challenging, end quote, target lesion?
Yeah, so there is micro-ultrasound in Vancouver. You want to look up Miles Mannis or Martin Gleave. Those are the 2 guys who do micro-ultrasound in Vancouver. Miles Mannis, Martin Gleave. And I see Jay Levine has his hand up for a while.
Yeah.
Oh, Jay, sorry.
Yeah, that's okay. So on the actual biopsy, either way you do it, you're getting a needle inserted biopsy. When the needle is inserted and it hits a positive cancer, obviously the needle needs to be extracted, and that also extracts blood and cells from the cancer. What are the percentages of people that have been found to develop a second lesion along the extraction line of the needle?
Sorry, so you're wondering what is the chances of the cancer spreading? Is that what you're saying?
Yeah, with the extraction
So
of the needle taking
yeah, so
cancer.
that has been studied before. And while there are some cancers that can seed, it's called seeding, seed the needle tracts, things like sarcomas are known to do that. Prostate cancer does not do that. Yeah.
Okay, thank you.
Sounds like we're going on a Canadian tour here. Chris Busby is asking, any micro-ultrasound specialists in Ottawa?
I don't know. I don't think so. I don't think micro-ultrasound's there yet.
Okay, similar question, I think, from a US perspective, from John Dulesky. He's saying, what about the big three cancer centers? Are they looking into micro-ultrasound, or do they need, and then the thing dropped down, or do they need a push from patients? I and I'm going to add something else to this, because I know back in 2018, I asked about micro ultrasound here in Chicago. My doctor kind of blew me off. And, and I got the idea that, and I suggested this earlier, these big hospitals want to feed their MRI machines. They have big overhead with them, and they want to keep shoving the patients through that. So they may not be enthusiastic about a cheaper technology that can be done in a doctor's office, right? But so what do you know, doctor, about? I'm not even sure who the big three are. Is it MSK, Cleveland Clinic? I don't know.
I saw up above in the comments someone referring to the big three. I think is MSK, MD Anderson, and something else. I don't know what it was, but yeah, I they are not participating in my trials. I don't know if they have the device or not. Um,
Well,
Certainly, if they have the device, I would love to have them in my trials. But very good academic institutions like Cleveland Clinic, Yale, UT Southwestern, UCLA, they all are participate. They all participated in Optimum and are participating in my trials as well.
what do you think about the medical politics and medical economics of this? Do you see that as an issue?
I'm proud to be Canadian. I don't have to deal with that as much.
Okay. Any other hands up? And we have about 8 minutes left
Don't
in this.
don't see any, but
I
I
have one
wanted to ask.
question from the chat
Oh,
box.
okay.
Am I on? Can you hear me?
Yeah.
Yeah.
Oh, okay. Micro ultrasound versus Doppler. Any comment?
Yeah, there's so Doppler is it's a setting on on ultrasound where you're imaging fluid movement, and there is Doppler on micro ultrasound, but we don't really use it.
Thank you.
Howard, kind of a question for the future. Now that we've got AI being used, Dr. Kinnaird has been kind enough to share how AI is presently being used in pathology, particularly for prostate cancer. Where do you think we're going next, doctor, with you know, both hardware and software and artificial intelligence? Where do you think we're going to end up here?
I'm happy that I'm trained to do something with my hands because I think that AI is going to revolutionize the way that we do things like radiology and pathology. I think that with large enough data sets, it will eventually become, the models will become as good as radiologists and pathologists. Certainly, you look at the large language models that look like they're as good on their medical licensing exams as physicians are. So I think that as society starts to trust AI and says, I am willing to have an AI radiologist tell me whether there's something on my X-ray or not, then I think that we will see a paradigm shift in the way that we provide healthcare. I do think that that is a ways away. And certainly as a surgeon, I think that it will still be a ways away before we're letting robots operate on us without a physician doing it.
Thank you.
So, we're coming up to an end unless there's some other questions. I don't know if the doctor can stick around later, but maybe
I have one question from the chat box,
yeah,
Howard.
go ahead.
I'll just read it, but it talks about the accuracy of biopsy in a smaller size, 7 millimeter. This says the RAD report indicated, quote, PIRADS 4 lesion in the peripheral zone, which will be challenging to biopsy given its midline, mid-region location and smaller size 7 millimeter. Is there a size that I'm in my own mind, I'm interpreting this as, I guess cancer comes in different sizes. Is there a size that's too small but still potentially lethal? And can it be detected? This is part of his question. He wants to know about detectability.
Certainly, in terms of the detection, the bigger the cancer, the more easily it is to be detected to put a needle through it. Certainly, in terms of the PIRADS scoring system, something that looks like PIRADS 4 by everything else, but is greater than 15 millimeters in size, becomes PIRADS 5. So you go from about a 60% chance of detecting it to a 90% chance of detecting it based on its size. I think that I can't really give a scientific answer as to whether there is a direct correlation between the size of tumor and the chance of metastasizing for prostate cancer. Certainly with kidney cancer, that has been established, but it would make sense that the more cancer cells you have in a tumor, the more likely chance there is of a cancer cell spreading somewhere else.
Thank you. Thank you very, very much. Back to you, Howard.
I think we can call it a day. I think Mark might have some parting words.
Yes, thank you. Thank you, Howard, for inviting Dr. Kinnaird. And Doctor, your presentation was outstanding.
Right.
The slides, everything was just impeccable. In fact, in my case, I mentioned early on to those who were on the call that my cancer spread, and I had an MRI 9 months ago, and I just made a note based on this discussion today to they wanted to do another MRI, but I made a note to request a micro ultrasound. Now I'm in the Poconos, so obviously I have to find out whether that capability is available here in Pennsylvania, but I plan on doing that. So,
Well, Mark,
but,
you certainly can get a uh, parametric.
but oh yeah, it would if I did the MRI, and all of my MRIs have been by parametric. I don't do multi-parametric MRIs. But to the general audience here, I just wanted to say we found that folks want to stick around after these talks, so we'll hang out for another 10 minutes or so. But I did want to ask the audience for your feedback. We posted film shorts, searchable film shorts on the website. So if you have a topic and you want to find out about that, you can go to a video, put the topic in, go to the video and get a 1 minute short on that topic. And we would love to get your feedback on these shorts. Do you find them useful? Do you find the searchability good? Whatever. So if you all get a chance, please do that. So
You're
we'll
referring to the
hang on
website
here.
of aspatients.org.
Yeah, thank you, Dave. Appreciate that. And you and Jeff did a great job too. And okay, that's it. We'll say goodbye to the doctor. And if anyone wants to stick around, you can stick around for a few minutes.
Thank you, doctor.
Thank you again, Doctor.